Greetings, my name is Dr. Sajad Zalzala. Welcome to the Sleep Dysfunction module preview. Today we're going to be talking about why sleep is both a signal and a driver of biological aging. Today is an optional Aging Academy module preview on sleep dysfunction. Before we jump into the module preview, I want to talk a little bit about your guide for today, me. My name is Dr. Sajad Zalzala. People call me Dr. Z. I'm a board-certified physician focusing on longevity and preventative medicine. I spent the last 2 decades learning about longevity and preventative health, and spent the last 10 years in telehealth, including being the co-founder of one of the first telehealth platforms on longevity called Ageless RX. I co-authored numerous papers. You can see part of my bio here. You can also look at my LinkedIn profile for more information. I've been an advisor to digital health and diagnostic companies at the intersection of medicine and technology. I really enjoy doing that kind of work. The framework that you're seeing today reflects my years of clinical pattern recognition, and not just theory alone. That's really important. A lot of the academic courses out there, a lot of courses by other physicians or by health coaches are much more academic. This course, the Optional Aging Academy, is my attempt to try to make longevity accessible to everybody by learning, understanding, assessing, and then intervening. We'll talk a lot more about that framework as we move on. All right, so what we're going to cover in this mini class today, this module preview, we're going to be talking about sleep patterns, how things like difficulty falling asleep, night waking, non-restorative sleep, how these are predictive. We're going to talk about the sleep archetypes. That's kind of a common theme across all of our modules, or the archetypes. The assessment framework, which is key to you have to assess before you know where to intervene, where to start. And then, issues with sleep regulation. And then we'll talk about some cases and we'll wrap up. So put your learning hats on, and this is going to be a bit of an educational experience. I hope you enjoy it. So let's take a minute to talk about why your sleep feels the way it does. So most people experience problems, and they think they're isolated. Things like falling asleep. Oh, doctor, I'm having trouble falling asleep. Or they wake up at night. Or they wake up in the morning and they're not refreshed. Most people think that these are in isolation. Now these symptoms are typically an indication of a deeper problem, and they're not random. They reflect how effectively a system can operate each of these parts of sleep that need to be operated. When regulation starts to falter, we start seeing these symptoms appear. So the symptoms aren't random. They're usually an indication of things going on deeper, and that's what we're trying to figure out today. What goes wrong with sleep, how to assess it, and then we can talk a little bit about what to do about it. So in every one of my modules, I talk about the core reframe. Again, sleep symptoms are not isolated. You shouldn't just suppress them or ignore them. They're feedback. They're telling you that something is wrong. It could be something with the sleep architecture itself, something with metabolic instability, inflammation, and understanding what's going wrong and listening to what's going on, assessing, is key to try to figure out how to optimize it. So why are we emphasizing sleep? I mean, sleep is what I would consider one of the essential drivers. It's the first one I put on my list. It's module 1. So in my opinion, it's the most important. If you don't get enough sleep, nothing else really matters. Diet, exercise, supplements, can flush all that down the toilet, because sleep will sabotage all that if it's not taken care of properly. Of course, chronic sleep disruption predicts things like metabolic dysfunction, cognitive decline. You see an accelerated biology of aging. Even the short-term sleep disruption. I mean, they've done studies on college students where they've sleep deprived them, and they have all sorts of metabolic and cognitive issues, as well as mood issues as well. Imagine what happens if somebody goes into a chronic state of sleep disturbance and suboptimal sleep. And the thing is, just like many things you'll see here, kind of the pattern is it's silent until it's not. So, usually these issues go on for years, and then eventually they'll show up as symptoms, and eventually they'll show up as something much deeper and more profound. And that's what we want to prevent. We want to prevent the deeper, more profound issues with health that can be caused by suboptimal sleep. And just like anything in the body, the easier you catch it, the better, the easier it is to reverse. It's called the reversibility window. If somebody lets their sleep disturbance go on for years and years and become to an advanced stage, it becomes harder and harder to bring it back into optimal. Not to say that it's hopeless, but again, I just want to emphasize, don't ignore it. It shouldn't be something that's ignored. So let's talk a little bit about the bottleneck. Well, first of all, sleep is not just about the number of hours you clock your head on your pillow. It's not just about sleep duration. You need to have appropriate initiation, you need to have stable maintenance, and you have to have restoration. There's a lot that goes on during sleep. It's not just an idle time. There's a reason why your brain expends so much energy on REM and deep sleep and the different phases of sleep, generating different waves. I mean, those are all there for a reason. And again, unless you assess, unless you measure those, you're not actually quite sure. So we'll talk a little bit more about of that in the module preview, and of course that's going to be a big focus in the full module. When we start seeing faltering in these points, then we start seeing fragmentation and suboptimal sleep. All right, so how do we assess? Again, as you see in a lot of the modules, there's two assessments typically. There's a subjective assessment and there's a targeted objective assessment. So with the subjective, it's usually a self-assessment, asking about symptoms, function, things like that. Whereas the objective is looking at various different biomarkers. By biomarkers, I don't always mean blood work. You can get biomarkers from a wearable, for example, from a DEXA scan, things like that. So we talk more about what the biomarkers are, and as well as the assessments. But these are, I've created these to be very deliberate and very actionable. The goal is clarity, not complexity. And in fact, some can argue that I've maybe simplified it a little bit too much, and we talk a lot more about that in the course. But I've made a very deliberate attempt to make these assessments as effective and accessible as possible. And that's not a small feat either. All right, so let's start with the subjective. Some people call it the self-assessment or the questionnaire. In most modules, you'll see kind of a 10-question subjective. Again, I've kind of deliberately created these based on my clinical knowledge, and experience. So you'll see patterns. So the subjective assessment will help you uncover patterns of things like difficulties falling asleep, early morning or nighttime awakening, and non-restorative sleep. So that's the importance of the subjective. And of course, anybody can do a subjective assessment. It's just a matter of filling out a series of questions, and then you can pick up patterns, and we'll talk more about that when we talk about the bottlenecks and archetypes. So some of the biomarkers that we look at for the objective sleep biomarkers are things like REM, the number of minutes you're spending per night, deep wave sleep or slow wave sleep, latency, how long it takes for you to fall asleep, and then sleep efficiency, or like what percent of your time is actually spent in bed. What percent of your time spent in bed is actually spent effectively asleep. And there are, of course, optimal levels to all these, and only by doing an assessment can you figure out whether you're optimal or not. And of course, these patterns help describe, or these markers help describe sleep structure. And then we'll talk about that in the next slide. So why is it important to have both of them? Because now we're integrating the subjective with the objective signals. And like I said, subjective is like how you're feeling, what the quality of the sleep is from your perspective. The objective is looking at it from a disinterested point of view in terms of what do the numbers actually show. Putting them together helps provide a more comprehensive picture. Sometimes you do need to go a little further. Some people may need like a formal medical sleep study, and we talk more about when those when to go for that sort of thing in the full module. But again, I've designed these assessments to be comprehensive but also accessible and not excessive. I know a lot of longevity clinics, they throw 1,000 tests at a patient. And it can be very overwhelming, and I've deliberately not done that with these modules to make sure we're getting just enough information to get us started. All right, so the key of the assessment is to figure out how you're functioning, but also then to figure out what the patterns are. So these are the patterns: difficulty fall sleeping, 3 a.m. waking, and then the unrefreshing sleep. So we'll talk a little bit more we'll talk about this in detail, how to go from the assessment to these patterns. We're going to talk about the patterns here in a minute. So like almost all the modules, you'll see these archetypes. Again, these archetypes are a way to try to categorize what's going wrong, to try to help students guide them into better interventions and intervention pathways. So the four archetypes that I've identified are I call it the tired but wired, the 3 a.m. waker, the fragmented sleeper, and the non-restorative sleeper. So each one of these has, at the end of the day, they're all not sleeping well, but there's different reasons for not sleeping. We'll kind of go through them. So the first archetype is the tired but wired, usually exhausted by day, wired and alert by night. So they're having trouble focusing during the day. They feel like they want to go to bed, but then at night, as soon as their head hits the pillow, it's like a switch goes off and they're wide awake. And there's a variety of different reasons for that cause this. Sometimes it could be physical, sometimes it could be emotional, mental. Typically, it has something to do with with cortisol and melatonin being out of balance. And again, we'll talk more about in the full course how to properly assess for it and then address those. Sleep archetype number 2 is the 3 a.m. waker. This type of person typically falls asleep early or on time, but has trouble staying asleep, and then when they do wake up, they have a hard time falling back asleep. So again, there are very specific reasons why this occurs. It can be different for different people, but again, narrowing it down to these archetypes can really help provide the best insights of what to do next. Number 3 is the fragmented sleeper. This person, typically falls asleep okay. Maybe they do have a little bit of trouble falling asleep, but they tend to wake up multiple times. It's not just unlike the 3 a.m. waker, which wakes up 3 o'clock, like their alarm went off. This person just, light sleep and kind of wakes up during the night. And so it's very fragmented. So they suffer from impaired sleep continuity. And, usually this is a pattern associated with, autonomic dysfunction, inflammatory dysfunction, hormonal instability and dysfunction. Like I mentioned in some of my other work, as much as I try to isolate sleep as a driver on its own, it's not. I mean, there are other things that tie into it. Aging is a web. It's not one thing here and one thing there. They're not in isolation. And that's kind of the allopathic. That's a problem with a lot of allopathic medicine, is that it tries to treat each thing in isolation, whereas what you really need to do, you need to look at the whole picture. But you got to start somewhere. So that's why I think starting with a module such as a sleep makes sense. And then within the module, I teach students how to figure out when it's time to move on and assess and intervene on the other drivers of aging. All right, now is the final archetype, number 4, the non-restorative sleeper. Again, they put their head on the pillow, their clock says that they slept, 7-8 hours, but they wake up and they felt like they haven't slept a week. Usually this comes about from just insufficient cellular repair. And usually because there's multi-levels of stressors preventing deep sleep and REM sleep. Again, you wouldn't know it just by looking at the numbers of hours a person spends in bed. So it's really important to try to measure that, and then you can better figure out what to do about it. All right, why does it matter? Why bother with these archetypes? Why not just okay, you have trouble sleeping, just jump right into interventions like some allopathic physicians do, for example. They pull out write Ambien, for example, because it's not a one size fit all. Treating sleep difficulties or insomnia, kind of the one size fit all, it might work for some people because inevitably you're going to have some people who respond because it's the right treatment for them, but it's not ideal, it's not optimal to just put everybody on the same treatment, kind of hope for the best, spray and pray, like some people like to call it. So these archetypes help identify the bottleneck, which then helps identify how to unlock the bottlenecks. And then it guides where to start, how to track, and then when to escalate to the various different tiers of therapy that we talk about during the module. And then a little bit more about how we match interventions to sleep patterns. Again, once you've understood the archetype and what are the possible reasons for the cause of it, then it helps you narrow down where to look. So identify the archetype, you initiate targeted strategies, And then if everything goes well, if everything goes as planned, then you restore regulation, and you'll see the assessments improve. That's the other thing about the assessments. They were designed to improve with intervention. They're not arbitrary. They're not asking your age, for example, because you can't do anything to improve your age. Your age is pegged on, when your mother gave birth to you. And you can't change that, obviously. So it's very important to try to figure out what the archetypes are. In the full course, we'll talk a little bit more about what happens if you have more than one archetype and things like that. But that's a little bit too much for the preview here. So pattern recognition determines where we begin. That's kind of the bottom line. In a lot of the modules, you'll see a tiered approach. There's usually tier 1. Sometimes there's a tier 0, which is more like lifestyle, and then tier 1, tier 2, tier 3. Some modules have a tier 4 or 5. In terms of what happens if you don't respond. And typically the higher tier therapies are meant for more advanced problems, or if you don't tolerate or don't respond. So I've deliberately, it's not like here's a list of all the things you can try, go ahead and try them. It's, this is based on your archetype, based on your patterns. This is what other people have responded to. Start with this. Big chance you'll get somewhere with it, but if you don't get as far as you want, then you can move on to tier 2 and then tier 3. And we'll talk a lot more about how the tiers are created, but I just wanted you to be aware that I try to think this out as much as possible in terms of almost like how I would treat patients. Again, this course is not a treatment. I don't. You're going to be my student, not my patients. But I am still a doctor, and so I think about my students just like I would think about how would I approach patients. And so all that information will be in the full module. Let's take a minute to talk about quick fixes. We already, touched upon them a little bit, but just in case I didn't hit it home enough, like I said, sometimes, getting on some biohack for sleep, or, a medication designed for insomnia, for example, sometimes it works. I mean, sometimes you put people on them and they work and they feel better, but they often fade. I see this over and over again, when they first started their medication or their supplement or their routine or something, especially if it wasn't focused, if it wasn't intentional or intentionally done within a framework, then usually the body shifts again because you haven't fixed the underlying problem. So it's like, it's almost like a boat that has multiple leaks, and you try to patch one leak, and then, oh, look, I fixed the patch the leak, and that might work for a little bit, but then usually you spring another, or there's another leak that kind of gets bigger as a result. So it's physiological adaptation, not failure of the treatment. A lot of people think, oh, but that treatment didn't work for me. Well, it may not have been the right treatment for you. And, there might be other things, other bottlenecks that haven't been addressed that need to be addressed. And I'm not against short-term treatment. We'll talk about this in the next slide. I'm not opposed to what I call bridge treatments, treatments to get your sleep better, for example. But like the previous slide said, typically the short-lived and not sustainable. So important as part of the sleep optimization, there needs to be kind of more foundational or bridge interventions, things like addressing stress load, creating a space for recovery. This has a lot to do with sleep hygiene and whatnot. Making sure you're not doing your taxes in bed, or reviewing court cases, or even listening to news, for example. And then again, when doctors do deploy medication, it should be thought of as like temporary while you're trying to find the underlying cause. And so for some people, it's easier to find that underlying cause than others. I'm not going to make it sound like, everybody can find their underlying cause, but if you don't look, you're not going to find it. All right, so what does success actually look like? The whole premise of these modules is to understand, assess, and then based on the assessment, do a focused intervention and then reassess. So the hope is that, the goal is that students will learn how to do the intervention more deliberately, and then things like sleep becomes more predictable, nighttime wakings become less, or just go away altogether, and then patients who weren't feeling restored in the morning start feeling more restored. Sleep is a very important function. That's why if humans go without sleep, I think for more than a week, they start going, they literally start going crazy. There was an episode of Star Trek: The Next Generation about it. Yes, I'm old school. But yeah, so it's a very essential function. Almost every single mammal or animal out there sleeps. I think dolphins maybe sleep with one brain, but that's dolphins. We're not dolphins. We're humans, and all terrestrial mammals, as far as we know, it's something that all animals have to do. It's a very important function. Um, so it amazes me how some humans just have a hard time with that basic human function. Imagine if you couldn't eat, for example. Well, there are some people, unfortunately, who can't, but imagine if you couldn't. I mean, eating and sleeping are like some of the most essential parts of living. So my point of all that is, properly intervening allows sleep to become more natural and less effort over time. That's the goal. All right, let's move on to cases. Patient, students like it when I talk about patients. So let's talk about the first case here. So here we have a person in their mid-40s, professional, reports falling asleep without much problem, but consistently waking up between 3 to 4 in the morning, and then it feels like their alarm clock has gone off. They can't go back to sleep anymore. They have a hard time going back to sleep. So that results in daytime fatigue, reduced resilience, because they're not getting restorative sleep. Their immune system starts to decline, and they start suffering all sorts of little things here and there. Cracks start showing in the system. So if we were to do an assessment on this type of person, we would see sleep onset's intact. They don't really have much trouble, but they have this 3 a.m. awakening, and they're groggy in the morning because between 3 o'clock and 6 or 7, whatever time they wake up, they're missing the key aspects of their sleep. Sleep is not linear, meaning that a lot of the structure of sleep, like REM, especially REM, occurs at the later half. And so if you're disrupting that later half, that whole system goes out the window. And so that's why it's really important to find the underlying problem. So this person would align with the 3 a.m. waker archetype. So the goals here would be the strategy would be to stabilize nighttime physiology, repair the underlying issues, the drivers, and then reassess and continue to try to optimize as much as possible. Some people with more moderate to severe, assuming they don't have a treatable medical problem like sleep apnea, some people may need to move on to other drivers of aging, like we talked about before, or escalate to different tiers. And we talk all about that in the full module. So what are the takeaways? Insomnia is not insomnia is not insomnia. There are different types of reasons for sleep disturbance. If you're treating the wrong sleep type, then you're barking up the wrong tree. Matching the strategy to the pattern can help give you the best chance and accelerate the results to optimization, accelerate your path to optimization, the quickest path. I mean, you can maybe get there, by meandering here and there, trying different things randomly. And some people do get there, but that's by chance. This system allows people to get there deliberately and not by chance. Reduce the likelihood of needing chance and luck. All right, so this is the case number 2. This is a case about a person who are sleeping is normal, but just won't stay intact. So it's a female in their early 50s, fallen asleep without much difficulty, but wakes up multiple times. Sleeps lightly, any pin drop happening, they wake up and they hear it. And usually this sort of fragmented sleep is gradual. It doesn't just happen overnight, pun intended. It happens over usually months or years, and usually set off by something. So what does the assessment show? Again, falling asleep, no problem. But frequently kind of going in and out of sleep, not quite making it to the structure of sleep that they need. And this is the archetype that we talked about before, the fragmented sleeper archetype. So the key here is to try to reverse the impairment with sleep continuity. So what are the strategies here? So we're going to try to improve nighttime stability, restore consolidated sleep, and then reassess to make sure that the interventions are working as intended. And then if not, then reassess the drivers to see if maybe this person needs hormones to be balanced before they can fully restore their sleep. Usually in my experience, you can get most of the way there by focusing on one system, but in order to get all the way there, you really need to then figure out what the other drivers are and assess those as well. And we talk about this in depth in the full module. So what are the key takeaways from case number 2? Fragmented sleep is different than the other problems within. It's kind of distinct failure mode. When most doctors think about insomnia, they think about trouble falling asleep. They don't really think too much about staying asleep. And so that's kind of the differentiation between treating suboptimal sleep and insomnia. And then in order to fully stabilize the sleep, in order to fully get all the way there, sometimes you need to move beyond the sleep module and look at other drivers. And that's why, like I mentioned before, it's a web. It's not isolation. All right, case number 3, when sleep quantity looks fine, but recovery doesn't. This is just somebody we'll talk about in a minute. This is a male in their mid-50s. They put their head on the bed for 7 to 8 hours, which is good enough for most people, but waking unrefreshed. Usually they have brain fog, low energy in the morning. Sometimes they can't get going until they get their coffee or, God forbid, Red Bull, or their energy drink, not to pick on Red Bull. So the impact is, they have because they're not getting restorative sleep, they have a gradual decline in resiliency, performance, both physical and mental performance. So what would the assessment show in this type of person? Symptoms are worse with stressor. They have a lower resilience, and so when they're under stress, they have a deadline, they're sick, things just become amplified at that point. And this is the non-restorative sleeper archetype. The issue is impaired recovery, not insufficient sleep time. So what are the strategies here? We have to help reduce the burdens on this person. We have to help them enhance repair and prioritize quality of the sleep, the sleep cycles that matter, the REM, the deep wave sleep, and then of course not waking up if the person's waking up. All right, so what do these cases reveal about sleep? Again, similar complaints. Doc, I'm not sleeping well. Different patterns, different physiology, different interventions to start out with. Sometimes there are overlaps with the interventions, but again, each archetype tends to have its own set of interventions that work more effectively than others. Pattern recognition is a key. It accelerates progress, faster course to optimization. And then, again, trying to understand what causes these problems and treating the underlying cause, the upstream results, or the upstream causes with upstream interventions typically gets you there faster as well. Sleep is not a single problem, it's a system signal. So now that we've talked about some of the cases and the archetypes, so what can you expect from the full sleep module? We expand on the assessment like we talked about. We go into detail with the subjective and the objective assessments. We talk a little bit more about the archetypes, their underlying causes. We discuss those in depth so that students can understand them a little bit better. And then, the stepwise escalation framework, now that you found or identified what archetype to start with, where to start with the interventions, and there'll be information on resources on how to get there. And then module integration. Again, I've probably said this 3 times already, but it's not, sleep doesn't work in isolation. It does depend on mitochondrial function, on inflammation, on hormones. So sometimes those have to be addressed before you can fully address the sleep problem. All right, where do we go from here? I hope you found this module preview useful. It helps provide an introduction to the framework that we use during the full module, the structured sleep assessment framework, identifying the archetypes and the bottlenecks, and then the stepwise like we've talked about. So from here, you can either, you can jump right into the full module. We also hold a webinar talking about the full framework. Or you can just follow us on social media or our newsletter to keep up to date. Thank you very much for attending. We hope you found this useful. And that's a wrap.